Well, I'm very pleased to be here, and it's a lovely location and interesting journey to get here. I think we've all had seen quite a bit of the Belgian countryside and city centres. So first of all, I guess I have a sort of confession to make. I am neither an epidemiologist nor a statistician. So this is very much an oncologist perspective, really, on how we interpret epidemiological data and understand where it comes from, and actually working with people for whom this is their bread and butter day job. I thought I'd put in some learning objectives, partly because I used some slides from a previous course, but I hope, to demonstrate some of the principles of childhood cancer epidemiology, the challenges in interpreting variation in survival rates, because I think that's one of the key things we always want to know. How well are we doing for our patients? Are we doing as well as it's possible to do and as well as our neighbours? And then how do we approach building synergies between routine cancer registration, which most countries in Europe have, clinical research, and kind of service quality improvement? And I hope that you will finish this hour, I think I've got an hour, but I'll try and be quicker, with a greater enthusiasm for the value of high quality data that you use in your daily clinical work, but can also use for both research, audit, and service improvement initiatives. So, cancer epidemiology, you'll hear these words all the time: incidence, mortality, survival, prevalence. These are terms that have key meanings in epidemiology, and the data that come out, most countries as part of their cancer control will measure these things for cancer at all ages, and they use them for planning health service requirements, monitoring efficacy, and if they have the right sort of data about things like people's social deprivation status or ethnicity, they can also look at equity of access and use of services. But actually, epidemiological data is an enormous value for research, particularly if you want to look at population outcomes and compare yourself to similarly resourced countries and healthcare settings to see if you're getting, if you like, the best value for your population. In terms of interpreting variation in survival rates, I want to touch on a bit about what we know about reasons for treatment failure and what we're trying to do about that. And then the third point is, as I say, working together with all these multiple people that use data, and how can we collect high quality data once and use it for multiple purposes. So epidemiology is one of those long words that everybody knows what they think it means, but it is the study that has to be scientific, systematic and data-driven of both distribution, so that's frequency and pattern of differences, and determinants. You're also trying to look at causes and risk factors of health-related states and events. And you are looking at a specified population. And as I've said, it's a cornerstone of public health. It's often being used as targeting prevention, which in childhood cancer at the moment doesn't seem to be a big a priority for us because it's not really feasible, but clearly we can do something about early diagnosis. But what I would say to you is the use of any data, really, but particularly epidemiological data, because it's not being collected necessarily for a specific purpose. When you dig into it, you need to look at it to test a hypothesis, and don't just go on a fishing trip, because you can do so many analyses that at a statistical threshold of 1 in 20, you will definitely find positive associations. So I was asked to include the word history in my title, so I thought, well, I'd just reflect back a bit. This Linnaeus, when he was sort of categorizing the plant kingdom, was saying, if you don't know the names of things, the knowledge of them is lost too. And I think it's very important that we can classify childhood cancers and do it in a standardized way so we can learn together and consistently. And so just to reflect on probably the first epidemiological observations that actually had a clinical impact. And for those of you who are old enough to be at the SIOP 2012 Congress in London, Mark Greaves gave a very nice speech in the opening ceremony about the history of medicine in London and highlighted this. So in the middle of the 1800s, London was a very crowded place. There were multiple different water companies who drew their water from the River Thames at various points as it flowed down towards the North Sea. And some of them tried to treat their water or filter it, and others didn't. And of course, as the population grew, more and more sewage was actually just being pumped into the river, which was then coming back in as drinking water. But at that time, it's quite remarkable, really. So this is even before Pasteur had actually sort of identified microorganisms, I think. There was this sort of two theories. It was bad air, miasma, or it was some sort of germ. So John Snow actually did a natural experiment. He worked out in central London. He traced all the households that were supplied by these two different water companies, one of whom took their water from slightly upstream and one slightly downstream, and worked out it was only the houses, and it didn't matter if they were a rich house or a poor house, or because there were lots of houses in this area, that the cholera seemed to be much 14-fold higher risk with one particular water company. And then there was this huge outbreak in Soho. This is Soho, if you've ever been to London. Here's Oxford Street up here, where you might have been shopping. And here is this infamous Broad Street pump. And so he convinced the water authority, when this outbreak, because lots of people were dying very quickly, to go and take the handle off the pump to stop people drinking the water. And whilst he may not have had a huge impact on the deaths, this was an observational piece of epidemiology that actually led to an almost immediate impact and intervention to help save lives. So epidemiology is about, what are you doing? We're looking at cancer, who, we want to look at the child, and in epidemiological terms, a child is somebody 0 to 14 years of age for cancer registration staff, but we also now increasingly look at 15 to 19 and then 20 to 24. You want to look at the entire population affected, and because it's a rare disease, you want to have data that goes over a sufficiently long period of time, otherwise you'll get small fluctuations that will look huge but probably not statistically significantly meaningful. And in terms of the why and the how, using this data to understand cause, risk factors, mode of transmission, obviously I just showed you that for an infective disease. But what I would say is over the years there have been many, many epidemiological studies, particularly in relation to potential carcinogen exposures, radiation, electromagnetic fields, maternal drugs, pesticides, drinking coffee when you're pregnant, all those things you were made to feel guilty about, I guess. And I would say that most of those studies are largely negative, or an occasional one finds a significant p-value. I have yet to be really convinced whether there's any real association between maternal ingestion of things and, AML in infancy. Carmelo might be. But, these are marginal associations. And the exceptions probably are the Chernobyl accident and thyroid cancer in Belarus, which clearly went up massively and then came down again. If you look at the melanoma incidence in Australia, it was going up, not just in young people as well as older people. And then they sort of brought in a big blanket government policy, became socially unacceptable to let your child play on the beach without a T-shirt and a hat. And in fact, they couldn't even go to school if they didn't have a hat, and sun cream everywhere. And that really has dropped melanoma rates. And then HIV and Kaposi sarcoma, particularly in sub-Saharan Africa, was, suddenly emerged. And then as HIV had a therapy, started to treat it, that the oncologists tell me in Africa they don't really see much Kaposi sarcoma anymore. But of course, there are also alternative hypotheses to explain apparent clusterings of childhood cancer. And for example, you may be familiar with Mel Greaves' hypothesis about delayed exposure of the immature lymphoid system to infections might then lead to proliferation of quite a primitive and potentially pre-leukemic cell. So population mixing rather than radiation from nuclear power stations is the sort of underlies the Greaves hypothesis. So coming back to, if you look at the cancer policymakers' eyes, how do they see childhood cancer? And how is it different? Do they know that it's different from adult cancer? So we have a problem, don't we? Because this shows you, and these are little diagrams from the IARC website. So collectively, childhood cancer is between 1 in 200 and about 1 in 20 in some low-income countries in sub-Saharan Africa, of the cases of cancer that are counted. But in most high-income countries, it's far less than 1%. We all know that childhood cancer is completely different biology, and that we should be reviewing it as development gone wrong, but how do we get that message across? That it is largely preventable, unlike a lot of adult cancers which have environmental exposure and lifestyle factors associated with higher risk, and that childhood cancers are different and need a different way of measuring them. They also have different staging systems, and I'll come on to this in a bit more detail later, but the traditional tumour node metastasis, TNM system, is often not appropriate for many childhood cancers. Many are not anatomically site-specific, sarcomas, neuroblastoma, and so on. And then we have this international consensus approach to staging childhood cancers for use by population-based cancer registries that's called the Toronto Guidelines. And here again, this is just to emphasize, if you put all the cancers occurring in people aged over 20 together, this pink line here is the carcinomas. There are still some in the age 0 to 19. These will mostly be in the adolescent age group. But you can see, that the hemopoietic tumours, the brain tumours, vanishingly small in the adult population, and embryonal tumours aren't there. So if you're going to study your population in great detail, and here we have at least 2 observers, we want to know that they're measuring and counting the same thing. So you've got to be able to distinguish your apples from your pears, from your oranges, and for whatever else. And so the International Classification of Childhood Cancer, a bit of a mouthful, this first detailed version came out in 1996. Prior to that, in the 80s, there was the Basil Marsden classification, I think. And this is the international standard system for classifying childhood cancer according to morphology. And it is the team at the International Agency for Research into Cancer, IARC, which is a UN agency based in Lyon, France, which is responsible for maintaining this and updating it. So this is a publication here. I haven't actually got the year on it. Can't quite remember when it was. But the ICC 3rd edition has 12 main groups, each of which is split into 47 subgroups. And here they are, the leukemias, lymphomas, brain tumors, they've all got numbers. And what you'll find, there is an other unspecified category, and number 11 is epithelial tumours and melanoma, which really only starts to emerge in children over 10. And here you can see leukemia, this is 0 to 4, 5 to 9, 10 to 14 years. And the embryonal tumours, so neuroblastoma, retinoblastoma, renal tumours, which are quite common in this younger age group, really are vanishing by the time you get over the age of 10. And if you go into these classification schema, you will find there are lots of different subtypes. They all have specific codes and names. So they have codes for the morphology and codes for topography. And basically, if you can't measure something, you don't know what's happening with it. And I've recently was asked to get involved in the new WHO classification of paediatric tumours, which is an interesting experience for me, not being a pathologist either. But I was battling to, can we have a code, please, for a diffuse anaplastic Wilms tumour? And it's not that easy to get a code for a specific entity. So at the moment, Wilms tumours all carry the same code, and it's not possible to put in one of these codes to say it's got anaplastic Wilms. But these are what are called the WHO Blue Books. So they've been publishing them for a very long time, and they are the kind of pathologist Bible. So if they get a funny tumour down the microscope, they'll be pulling out, and they're sort of site-specific, mainly. And this is the new one for brain tumours. But for the first time ever, they decided it was time now to create a blue book for paediatric cancers. Up to now, paediatric cancers have just been a little bit of a chapter in each of the site-specific books. And of course, as you can imagine, some of them didn't really fit easily anywhere. So Ian Cree, who is a pathologist based in IARC in Lyon, decided that he would create this paediatric tumour book. And I got asked to take part in it after I'd attended a workshop on the Toronto staging guidelines just prior to SIOP 2019 in Lyon. So we've done nearly all this work online, but it's actually quite good because it's quite a global community, it's quite mixed. And Stefan Pfister, who's also an oncologist, I'm sure many of you know, based in Heidelberg in Germany, he together with Rita Alagio, who's a pathologist, wrote this summary of all that work, which has been published as a paper. So please be aware that there are ways to count and name childhood cancer, and that sorry, I should have gone back one, because one of the criticisms, and it came from Eric Buffet, my dear predecessor as SIOP president, saying he was very worried about the emphasis on the molecular classification of the medulloblastomas and other brain tumours, because how are you going to apply that around the world? Because these books are meant to be usable in any global setting. But I think one should also look at it the other way round. If you can much more accurately identify children who maybe don't need so much radiotherapy, a lower dose, or don't need it at all, actually, shouldn't we be trying to get the tissue to the molecular test rather than the molecular test to the child? I mean, as we just heard from you. There are ways to get around it, I think. So, very simple question, you might think. How many new cases of cancer in children are there annually in the world? So let's start with the epidemiological definition of 0 to 14 years. Anyone want to hazard a guess? What have you read about? Is it controversial? Do you have a number in your head? 8 billion people on the planet? Nobody want to have a guess? Okay, well, we'll keep going. So these are the people who are officially responsible for counting, which is Freddie Bray, Ava Stelio-Rover-Fouché, and the team at IARC. They are the home to GLOBOCAN, which is the global sort of catalogue of adult cancer, of all cancers at all age. And if you go on their website, you can select your age group, 0 to 14, 0 to 19. You can select your region, and it generates all these lovely graphs of incidence, mortality, survival. But are they accurate for children? And if you talk to the experts, Ava and Freddie, they would say, no, they're not, because they're not designed for childhood cancer. And a lot of children's cancers get put in this other category, which for reasons I don't fully understand, doesn't always get counted as cancer. So Ava has led the International Incidence of Childhood Cancer study that has been in various iterations. This is the most recent publication, so looking at cases diagnosed over the decade that ended in 2010. And I think what you have to note here is that it also includes the non-malignant neoplasms of the brain diagnosed before age 20. And they're only working with population-based cancer registries. And they invited 532 cancer registries, of whom in their paper appendix it says 308 out of 420 provided high-quality data. But in the end, only 153 actually met the quality standards and had data across the entire period. So there's obviously some biases creep in here. But, you know, fairly large numbers of people, nearly 400,000 cases, but that's over a 10-year period. So that's only like 30,000 a year of children actually measured in a registry with cancer. So what they do what epidemiologists love to do, is they calculate age standardized population rates. So I won't tell you how many cases there actually are, but they're very, very precise about the risk. And in children 0 to 14, it's about 140 per million person years, and it's slightly higher in adolescents. But what does that mean for us as oncologists, seeing these children walking through the door and wanting to know how many are there in our country and so on? So here's part of the problem. So these are the registries that were actually included in that analysis. So the green ones are national cancer registry coverage. The yellow are countries that have population-based cancer registration, but it doesn't cover the whole country. And the red, and there's always whatever you measure, there's always a big hole in sub-Saharan Africa. It means there's no registry at all. And I think as of today, still it's only about 15% of the world's population is actually covered by population-based cancer registration. And most of the data that we're going to look at comes from high-income countries, and the true incidence in low-middle-income countries is probably vastly underestimated. So how do you assess the quality of a cancer registry data? So they will look at things like microscopic verification rate. And this should be, obviously whoever is receiving the data will set their own thresholds, but a level of about 80% is acceptable. Why is that? Because, of course, not every cancer gets histological diagnosis. You know, brainstem gliomas, sometimes things are not biopsied, but they're clinical diagnoses. You want a very low death certificate only rate. And you also, coming back to that blue book, wants to see a low, not otherwise specified rate. So it means the pathologist has had a high-quality specimen, or their own ability to classify the tumour is sufficiently expert. So this is a variation in the overall incidence of childhood cancer by geography. So, sorry, it's a bit small. The top here is North Africa, and then Sub-Saharan Africa. The blue dots are the average. So what you'll notice is, and this is South Asia, that quite a few places of low middle-income countries, the incidence rate's a lot lower than it is in high-income countries. And this is the rates in incidence rates in teenagers. But what you've got to remember is, what does the population age distribution actually look like? So here on the right is the UK, and here on the left is Ghana. So our children, the age group we treat are the bottom 3 rows. So even though the population of the UK and Ghana are not that dissimilar, well, we've got 66 million, they've got 30 million, but they've got at least twice as many children per million of the population compared to the UK. And if you go to Japan, only about 11% of the population are under 15 now. And many Western countries, this is shrinking. And there's not enough children. I was glad to see a baby here earlier on. So you must know the age structure of your population to know anything about the numbers of cases coming through. And because the ICC paper I showed you, it's really important source of data. It took a very long time for it to be published, but it is very high quality. But they still have to make some compromises. So in order to have any population-based data from countries like Uganda and Kenya, they've had to accept, lower Zimbabwe, lower rates of microscopic verification, higher rates of not otherwise specified, and some relatively high rates of death certificate only. But if they rejected those registries, there would be completely no data at all. So I guess it's a balance. And so the other point on this is that the other thing is that using cause of death on death certificates to identify cancer is problematic, because cancer might have already been present. A childhood cancer survivor might die of cancer and perhaps never have been registered. But if they die of something else, the cancer may not be listed. So it's hard to use that as a quality indicator. So here we go. I've really pushed, because I know Ava quite well. I've worked with her for a number of years, and I was just saying to Lars earlier on, I'm always asking Ava, come on, give me your best guess as to how many new cases there are. And she was preparing for, the director of IARC actually gave the keynote lecture in Lyon. And so if you're interested in epidemiology, you should, I think it's still on the SIOP website. Ava had to prepare some data for her to present. And I think this is a slight update of this. But this is what the epidemiologists will tell you. And of course, this is not all measured cases, because I just showed you they only actually measured about 30,000 a year. But what they do is they are prepared to extrapolate a bit, but they'll only take the actual measurements. So they'll take those incidence rates from Kenya or Uganda and assume that they're similar in countries that don't have a registry in Africa. So about 250,000. I think she's managed to go up to 279,000 now, the last time I spoke to her. But that's the number. And the age and this is now what happens if you go to GLOBOCAN. So if you go into the GLOBOCAN website and choose your age 0 to 14, this is what it will show you for the incidence rate. So this is also based really on extrapolating from actual measurements in neighbouring countries. But it doesn't have the right classifications. Now, Zach Ward and colleagues, they've done this huge modelling of both incidence and survival in childhood cancer globally. And they have come up with almost a mirror image that actually they think the rates are even higher in parts of sub-Saharan Africa if you look at things like the rates in the similar ethnic populations in the United States and some of the small areas of Africa that do have cancer registration at a fairly reliable level. And they reckon, in this estimate, 224,000 cases are actually diagnosed, but there's nearly 400,000 estimated in total actually happening. And again, there's huge amounts of information in these papers. They all came out quite recently. And this is what it looks like with the geographical distribution. So here, the green are the ones actually diagnosed, and the orange are the ones that are estimated and not diagnosed. And what you'll see down here at the bottom is that East Africa and West Africa, they're estimating that about half the cases are never diagnosed. And even in high-income countries, the modelling would still suggest a small number might go undiagnosed. And certainly we've seen this last year in the UK and probably elsewhere in Europe. In adults, we have got a whole load of patients with lung cancer who are missing and will probably never be diagnosed. I mean, they just didn't come to the hospitals last summer. And the numbers of new cases of lung cancer has just gone right down. It's starting to rise again now. And you can imagine why, people with symptoms didn't go to the doctor because they were told not to go if you had a cough or whatever. Then they died of something else and no one ever knew they had lung cancer. And this is probably what's happening with many children with leukemia or even, Wilms and neuroblastoma, big abdominal mass. People think they've got malaria and they die and nobody ever knows they had cancer. Now, with my dear friend Scott Howard and his wife Kath Lamb, who are based at St Jude, we did a much less sophisticated back-of-an-envelope calculation for the numbers of children with cancer in the world. And we simply said, let's assume everybody has pretty much a rate of 140 per million children, and let's calculate the number of children in each region of the world and work out how many cases there should be. And we actually came to a number that's not far off what Zach Ward did, of just over 400,000. But in fact, we were looking at 0 to 19-year-olds, and we estimated about a third were never diagnosed. And Scott produces what he calls an incident deficit map. So where are the children who are not diagnosed? And they're, of course, mostly in the low and middle income countries for reasons we can come on to. So finally, Nikhil Bhakta, who's also in the St Jude Global Programme team, working at St Jude, and colleagues, so Michelle Coleman at the London School of Hygiene and Tropical Medicine, the team from IARC, the team from modelling in Harvard, have done a very nice paper trying to compare all these ways of calculating how many children there are with cancer in the world. And this is a bit, I have to tell you, I'm not sure I fully understand myself, so you better go and read it yourself. But this is a comparison. There are two major things, GLOBOCAN, and there's the Global Burden of Disease initiatives. And I think this is a slide from Claudia Alemany, but I think the brown boxes are basically highlighting how many children are in this other diagnosis if you just use ICD-0 codes rather than ICC-3. So about 30% of children with cancer are not captured by these methods, and therefore, both incidence and mortality. So please don't use them. Try and focus on the work that's been done specifically for childhood cancer. Now, where you can have patient-level access to childhood cancer data by someone who actually knows what they're doing, which in this case is Dr. Keo Nakata, who I first met. She came to do a one-year fellowship at the London School of Hygiene and Tropical Medicine in the cancer epidemiology groups there. And she brought with her her own data set of Japan's children. And she had access to all the children in England because that group had the English cancer registry data over many decades in their research databases. So she produced these lovely comparators. And of course, you can't get a more ethnically diverse group, I think, than the British versus the Japanese. Well, I mean, we're fairly mixed in Britain, but we're certainly very different from the Japanese, I think, in terms of gene pools. And what's really struck me is just how, when you've got big data sets and they're being analysed by someone who really knows what they're doing, just how different things are. So here, these are the three tumour types, Hodgkin's, renal, which is mostly Wilms, and Ewing's, where there's an enormous deficit of the incidence rate in Japan compared to the UK, or it's actually the English data. So blue is England, yellow is Japan. So they have about a third the number of renal tumours. They have almost no Hodgkin's lymphoma and Ewing's sarcoma. Of course they do, but it's a much lower rate. And then the other way around, there are many tumours where they actually have more than we do. For example, ALL, some lymphomas, intracranial germ cell tumours, much higher in Japanese, and neuroblastoma, which I'll come on to in a minute, is a slight enigma because they did a screening program. So if you have these sorts of data and you can analyse them by someone who knows what they're doing, actually you can get quite a bit of learning. So there clearly are big ethnic differences in susceptibility to childhood cancer. It doesn't mean these children necessarily have a genetic predisposition. It just means that their genetic makeup means they're more likely to have that cancer than another one for whatever reason. Now, if we look at incidence trends, so is childhood cancer getting more common? Now, this is Ava's other pet project, the Automated Childhood Cancer Information System, otherwise known as ACIS, which is based in IARC. She has recently published the incidence rates over time from that database. And there has been an average annual percentage change going up the way in all parts of Europe that varies between 0.4 and 0.7% per year. And here on the right, you won't be able to read it, but let me just check. Yeah, the blue bars are the previous international classification incidence of childhood cancer number 2 that was published in the 1980s, and then you got the most recent one, which is the red line. So you can see, and these are parts of the world, sorry. So this is Africa. Sub-Saharan Africa, the incidence has actually gone down, but that might just be because they're not counting them as much. And most parts of the world, it is going up. So what can incidence trends tell us about causative factors? I've already mentioned the first 3. But the COVID pandemic, I think, is probably giving us a real-life test of the Greaves hypothesis, and we can debate that. And I've just come back from the SIOP Africa Congress, where 2 of my colleagues, one in Uganda and one in Cameroon, said that their impression is that the typical endemic form of Burkitt's that affects the jaw seems to be much less common, and is it really driven, because malaria rates really are falling in sub-Saharan Africa now. Is it that that's genuine, or is it that they're now doing much better imaging of the children and recognizing that they also have abdominal disease? Certainly Peter Hessling, who's helped children's cancer services in sub-Saharan Africa for a long time. When I asked, I posed this comment to him, and he said, well, maybe they always did have abdominal disease as well as the jaw mass, it's just nobody knew it was there because they didn't have an ultrasound. Yes?
Could it also be because you changed from version 2 to 3 that there is less other, and that therefore it seems that there is an increase, but it's actually the classifier?
Here they were talking about the clinical presentation, actually, because the typical endemic one is the children with the big swollen jaw, and it seems to just melt away with very little chemo. These are the kids that Peter Hessling started treating with just 4 weeks of cyclophosphamide and 1 lumbar puncture. With Oh, this one here.
Yeah, could the increase also be caused by... Because blue and red is version 2 and 3, and maybe there's less other in version 3, so we have more diagnosis?
But this is total numbers. This isn't subclassified. This is the international incidence of childhood cancer publications. But let me show you a very stark and obvious, so again, this is Kaio Nakata's work. So in Japan, they had a national screening program for neuroblastoma based on urine testing that ran for almost 20 years. And it was done in infants at the age of 6 months. So you can see that back in the 80s, their incidence of neuroblastoma was massively higher than it was in the UK. But the government actually terminated that program in 2004 because they were basically just detecting the so-called self-healing neuroblastomas, and there was no impact on mortality from neuroblastoma overall. So you have to know what's going on in the country to detect cancers as well before you can really use the data properly. I've mentioned this, but I just wanted to point out this recent paper that just came out from the German cancer registry team and others, and they have modeled to suggest that they think they're seeing an increase in ALL during COVID era in both 2020 and 2021, and their modelling is projecting that maybe up to 99, so about just over 5% of all cases might be attributable to children, not directly COVID, I think, but having been isolated and then put back into normal social mixing and getting lots. So the COVID pandemic is going to give epidemiologists enough work for the next 40 years. So I think it's a really good time to become a childhood cancer epidemiologist. There's lots of interesting natural experiments have happened. So to summarize, you must be able to differentiate your apples and your pears and even your red apples from your green apples, your subtypes. This just reminds us that the incidence data comes, this is North America, nearly every child's in a registry. In Europe, it's about 2/3, and in some parts of the world, it's extremely low. And of course, these bubbles here, this green bubble over Asia And this red bubble over Africa, the size of the balloon shows you how many cases there are estimated to be in those continental areas. So North America, Europe, and Australasia contribute a very small proportion of all the children with cancer in the world. So I want to move on now to mortality. Now, this is much easier to measure because most countries require people to report deaths. The problem is the cause of death reporting is much more variable, and cancer often may only be mentioned in the second or third line of a death certificate. And as we've already said, if a cancer is only registered because the child's already died, it's not very high quality data. Countries that don't have population-based cancer registries will try and use mortality and incidence ratios as a way of trying to evaluate the efficacy of their cancer services. But it is actually difficult. You know, the deaths in a year, especially if there's no personal identifiers that you can link back, you don't know when that patient was diagnosed, so you can't really estimate survival very accurately in this way. But it does seem that you can track mortality to say, you know, are we making an improvement? And these are data from Europe, again, done by Ava back in a paper we did in 2013. So the former socialist economies, the mortality is coming down. All other European countries, it's coming down. And there was a suggestion towards the end of the last decade that the gap is closing. But just a little word of warning about using just incidence and mortality to estimate survival. So this is lung cancer in England up to 2008. So these are the numbers of cases in men starting in 1982, so coming down massively because men just stopped smoking. And the mortality has really just gone down along with the numbers. Women, the incidence is actually going up a bit more, probably because more young girls are smoking or starting smoking earlier. But what you'll notice is the survival rate hasn't changed at all. And that the decrease in mortality is purely because there's fewer people, so there's been no impact on survival. Now, of course, this whole scenario may be changing now, almost certainly is, because many countries have introduced low-dose CT scanning of people who've got a 20-pack-year smoking history. And so they're diagnosing lung cancer earlier, so the incidence is likely to go up, but also the survival will artificially go up because you are diagnosing patients earlier who will therefore inevitably have a longer living time, even if the treatment you're giving them is no more effective. Of course, we've had all these exciting immunotherapies in adult lung cancer, but the worry now is that there's been all these missed and late diagnoses in the COVID pandemic. So I'd like to move on in survival, because I think with survival rates, the key thing is about the benchmarking and trends. And this is really only possible if you can do international comparisons. So the data that I've already shown you, the permissions for how you use this cancer registry data are actually dictated by the registries who share their data. So they've given their data to IARC for this ACIS project to do both incidence and survival. The Eurocare team, who are based in the National Cancer Institute in Milan, only have permission to do survival. And then that International Incidence of Childhood Cancer 3 study, which I showed you several pieces of, has only published incidence. And you can imagine it's much easier to count cases at the beginning than it is to know what happened to them later, because then registries have got to be able to follow them up and give you follow-up data. They've got to have a way of linking their cases to the National Death Register, which isn't always easy in many countries. And then there's lots of different complicated methods for calculating survival, not all of which I completely understand because I'm not an epidemiologist or a statistician, but what I do know is that in children, in general, the competing risks for death are very low. So most of these models of how you measure survival give you almost pretty much the same results. So we've known that there have been variation in survival rates between European countries and regions, ever since we started looking at this. This is the western side of Europe, this is the eastern side, this is the 70s, the 80s, the 90s, when survival rates have probably got to about 75%. They're now up to about 85% in most parts of Western Europe. And then this is a Eurocare 5 data, which is effectively the same data. I mean, the different registries, so these are the two groups in Europe that have looked at survival rates historically over the last 30 years. And I'm hoping I've sort of tried to get them to talk to each other a bit more. So Gemma's based in Italy, Ava's in IARC. They've got their different sources of data, but fundamentally they're coming from the same cancer registry. So it will depend slightly on what quality thresholds they set as to what they use. But you'll see the same thing here, that Eastern European countries have both more variable and overall lower levels of overall survival. But even here, you can't see it very well, but I'm always interested. The UK is slightly worse statistically than France and Germany, just because the three countries have got very large and similar populations. So we'd like to understand this more. So variation in survival by country, can be due to a variety of things. Of course, if you're not counting the same thing, or if you're including brain tumours that one country thinks they're benign, so they don't include them, and another one does, then obviously their survival rates will be different. Completeness of follow-up, especially links to mortality. But tumour stage, this is a key thing. How advanced are the tumours at diagnosis? And then all these other things, of course, can affect survival rates, the quality of the treatment, the risk factors, the tumour biology factors. And these may vary by ethnicity, but access to treatment, access to clinical trials. So first, the good news is that childhood cancer survival in Europe is still improving. And this is the average percentage change in 5-year overall survival across Europe. So it's just over 1%. And in fact, Gemma showed at the recent European Parliament event online for International Childhood Cancer Day this year that data that I hadn't seen before that suggests that the survival gap is actually continuing to close, which is good news. But how do you look at survival in the rest of the world where there's hardly any registration apart from the United States and Australasia? So again, this comes back to this group with Zach Ward as the first author. And they've done some incredibly sophisticated modelling, looking at difference, trying to work out who's diagnosed and who misses being diagnosed. If you're diagnosed, are you likely to access treatment? Are you likely to abandon your treatment? What sort of care will you get? And they've tried to look at survival rates, estimate them rather. So sadly, again, the big black or dark red hole falls mostly over Africa and parts of Asia. But again, this is an estimate to show you the inequality in estimated survival rates from childhood cancer across the world. Now, there is a study called CONCORD that is led by Claudia Alemani and Michelle Coleman at the London School of Hygiene and Tropical Medicine. I mean, wouldn't you love to publish this paper? Individual records for 37,513,025 patients. But it's unbelievable how they handled these data. But this was done before GDPR got even more strengthened. And they did have 2 childhood cancers in here. They had ALL, and they had brain tumours as a category. So the thing to notice here is there are no data for childhood ALL for Africa, which is grey. So if you go to all the adult comparators, there's grey curves, grey bars, but Africa's got no data here. And you can see the extent of variation for ALL. But Michelle and Claudia are now gearing up to do CONCORD 4, and they're expecting to get data on all childhood cancers. And I've got a link with them with one of their PhD students who's going to be looking at the renal tumour data. So this is population level data. So really massive, massive effort, but really important that this sort of thing is done. But of course, overall survival just says, are you alive or dead? And we're oncologists. We're interested in much more than that. Of course, we want to cure our patients, but we want to cure them at least cost, and we don't want them to have late effects. And we all know that one of the most important things that affects prognosis is how advanced the disease is at diagnosis, and that you can measure this by tumour stage at diagnosis. And then there are many other what were called non-stage prognostic factors that are used in clinical risk stratification and selection of treatment. So I got roped in, I might say, or I suppose this is when I got a major interest in epidemiology, was when SIOP was held in Toronto in 2014. There was this workshop organised the week before by Sumit Gupta, who's a paediatric oncologist who's involved in the POGO, which is the Paediatric Oncology Group of Ontario. Joanne Aitken is the director of the Australian Cancer Registry. There's a lot of very important names here, but people from all over the world, Elizabeth Molyneux from Malawi and others, Oscar Ramirez, and Ava's there too, yes. So we were asked to take part in a Delphi process to say, what were the most important factors in staging each tumour type, and that could be compared across the world regardless of what treatment protocol the child was being put on. And this got published in 2016. It's called the Toronto Consensus Staging Guidelines. And it is actually much more applicable to childhood cancers than the classic TNM for adult cancer. So just to emphasize, these are not intended to replace staging systems for clinical trials, nor are they intended to replace or guide clinical decision-making. But they are intended to allow standardized comparisons of the anatomical extent of disease at diagnosis between populations. And it's been constructed in two ways. So tier 1 is very simple and should be able to be applied in places that have very limited clinical resources and maybe can only do a chest x-ray or an ultrasound. And often that's just localized or metastatic. And then tier 2 has much more detailed criteria which are expanded and then different by tumor type, but they can be collapsed down from tier 2 into tier 1. So in Europe, working with Yamagata and the population-based cancer registries, we tried very hard to do some studies where we could pull together, apply this Toronto staging through the population-based cancer registries to we selected 2 tumours, Wilms tumour and neuroblastoma. And what we found was that the registries could acquire the necessary clinical data to assign the stage in 95% of both tumours. And we only asked them to look at 1 year because it's quite time consuming and we wanted to make sure they could do it. But what it really did was help us establish a network. And now we've been able to work together to obtain funding to do a bigger study that we're calling Benchista. But before I get on to that, so Joanne Aitken has just run with this in Australia. And she has the advantage, she's only got 9 centres. She has a single cancer registration officer who's worked with her for 20 years, I think. And she actually went to each of the centres and dug out the data. And of course, they don't have that many children in Australia. But this is the first time ever a cancer registry has published population survival by stage for all their tumours. It's really important that we have this sort of data because then when you run a clinical trial and you try and say, well, our survival for metastatic Wilms tumour is X. Is that good? Is it? Sorry, I just got a tick. You need to know it's reflective of what's going on in the whole population. And up to now, we didn't have any data on survival by stage for the whole population with that same disease that's in your clinical trial. So this is the Benchista project. It doesn't have any results yet, but we hope to have some by this time next year. We've got 70 population-based cancer registries from 30 countries, mostly Europe, but includes Australia, Brazil, Canada, Ontario province, Japan, and the USA, Boston area. We're going to look at 6 solid tumours, neuroblastoma, Wilms, medulloblastoma, Ewing's, rhabdo, and osteo. And we're going to ask each registry, or we already have, we've agreed the data collection protocol with them. Thank you so much. And we've made it absolutely maximally depersonalised. But boy, oh boy, it's taken us 15 months since we started this project. And we haven't to just about get agreement on this data transfer agreement, it's going to have to be called now. And all the data is going to go to Milan and they'll do the analyses. But I mentioned it to you. I know many of you are not epidemiologists, but we're asking the registries to link with their clinical centres to get the information that they need to assign Toronto stage. And it's hugely different in different countries. So, for example, in Belgium, the Belgian Cancer Registry have trained their 9 paediatric oncology treatment centres to assign Toronto stage in the clinical team, because the registry staff are not allowed to look at the hospital records. Whereas in the UK, they can. And then in Germany, I know Claudia Spix, she has to rely on the clinical registries giving her the staging data, and she gets it often a long, long time after the patient's been registered. But of course, if you've got data yourself and you've generated it through a clinical trial, and it's very rich data with stage, histology, treatment, you know, if the patient's relapsed or not. You can do all sorts of interesting things with it. So we've just recently, and this is Joaquim Catano and Beatriz de Camargo in Brazil have led this with me. We've looked at this SIOP Wilms tumor trial, which enrolled patients from 2001 to 2011, and said, are there differences in tumor characteristics and outcomes by national groups? And the groupings we chose were GPOH, that's Germany, Switzerland, Austria, France, CCLGs, Britain and Ireland. We've then got Scandinavia, Belgium and the Dutch. We've got Brazil here, and then we've got the rest of the patients in SIOP, which is mainly Italy, Spain, and some other European countries. And what you notice here, volume at diagnosis, is that the tumours are bigger at diagnosis in the UK than they are in any of the other groups. Brazil's probably a bit of an outlier because we know they only enrolled approximately 10% of the population incidence in this trial, whereas most other countries in Europe were enrolling nearly everybody. And when you look at the stage distribution by national centre, again, it's skewed. We've got a more unfavourable stage distribution. And then you look at event-free survival. So this is, to me, one of the most important things we can tell our parents. What's the likely success of the first-line therapy we're going to recommend for your child? Knowing everything we do about their tumour, how far it's spread, its biology, its histological subtype and everything. We're going to give you treatment X, and we expect this is what's going to happen 5 years down the line. So what we found in these, and Harm, who's coming tomorrow, next day, he's done all these analyses, Harm van Tinteren, is that France and Germany indistinguishable here at the top. This is just, so we've taken away the metastatic disease is interesting. In terms of outcomes, there was no variation, but it's the localized tumors where you're really fine-tuning and trying to maximize cure rate without too much cost, where perhaps it makes the most difference. So here's the CCLG group, and here's Brazil. So in this type of effectively univariable analysis, we were, the log rank is highly significant. But once you do the MVA taking account of tumour volume, tumour stage, histological subtype and so on, in fact, the CCLG is doing as well as anybody else. The hazard ratios aren't any different, whereas for Brazil, it's still a little bit worse. But we know that they do have issues with treatment, maybe not so much acceptance, but tolerability and toxicity. So I think, you all work with people like me and Carmelo who's sitting on this sort of data. And the reason people don't analyse it in this way is perhaps because they're a little bit scared of what it might show and nobody wants to look worse. Whereas I've always felt, I'm looking at Amos and here, stand on my soapbox, we know we have a problem in the UK, we need to understand it so in order to do anything about it. And I know that some of the countries you come from would be too small to get an individual analysis like this done, but don't be scared to do it because I think it does help you understand where you are now, why is your survival maybe not quite as good as other people's, and what can you do about it. And again, coming back to the power of having data in your own hands, this was another nice analysis done by Keo Nakata. She looked at change in 5-year survival. Again, remember, this is now just overall survival. The previous one was success of first-line therapy. And she compared England and Japan for all childhood cancers. So if nobody answers this, Carmelo has to answer. What's the most striking thing on that graph? And what do you think caused it? So this is improvement in 5-year survival. Which cancer is sitting up here? Well, you can't see it. Chronic myeloid leukemia at the top right. Time period. What was the intervention that caused that? Yep, imatinib, almost certainly. And everything else has gone up a bit. Most cancers have got a bit better fairly slowly. Remember, this is about a 20-year, 15-year period. And I was worried about infant neuroblastoma in the UK not being good enough. In fact, we've just done an analysis that's taken forever with AVA. But in fact, our survival rates aren't any different to the other countries in Europe, which is great news for me. But what we need is new approaches, really, to do cancer outcomes research, cancer epidemiology research, and we need to focus on collecting high-quality data once and reusing it. And I've just mentioned, population-based cancer registries, but children are only 0.5% of all the data. We are almost at complete European coverage now, but they're not resourced for research. And so again, get to know how cancer registration happens in your country. Find out, do they want a clinical interface? And I'm sure if you've got the time and you're looking for a research project, there would be ways to work with your population-based cancer registry to help them get more out of their data. We've then got zillions of data items in routine health records. And then, of course, we've got the Paediatric Oncology trial groups. And then we've got the real experts, some of whose data I've shown you, who know how to do this type of research. And what I would really like to see is that we can sort of bring it all together. And I know lots and lots of people talk about this, and everybody say they want it to happen. But one of the issues is that we've got into this sort of quagmire of information governance and data protection that seems to me totally focused on the risk of potentially re-identifying somebody rather than the massive benefit of being able to do this sort of work more seamlessly. And nowhere has it been better illustrated than the benefits of big data is the COVID pandemic. Being able to write to patients and say you should be shielding because your primary care data was allowed to link up with the health service and so on. And to know that we've got lung cancer patients we don't know where they are. We need to go out and find them and so on. And we've got various funding to do this type of work. And just to emphasize, throughout the patient journey, there is a massive amount of data, and perhaps the most difficult to access is patient-reported outcomes and patient-reported experiences. And I'm glad Lars is here with PanCare and survivorship. But, patients actually want to give us their data, I think. And it's a question of how do you both inform the patient what's happened to them so they can look after themselves, but also give them the opportunity to share their long-term outcome data with people that could do further research. And so I'm pulling a bit over time, but I've almost got to the end. So global data sharing initiatives. In 2019, this very inspirational Dr. Sam Volkenbaum, who I only met last year, initiated something called the Paediatric Cancer Data Commons. I think he got one of the big awards at SIOP from one of our foundations, so he could set it up. And he is now working to share completed clinical trial data sets, and he's got multiple groups across the world into what's called the Paediatric Cancer Data Commons. And they've got a very, very nice annual report. It's only 12 pages long, and you'll find it on their website. And I'm very embarrassed that the only tumour that's not on this list is Wilm's tumour, but I'm doing my best to get it in there now. But the Americans keep saying, but you don't stage the same as us. And I said, well, no, but neither do neuroblastoma or rhabdomyosarcoma or whatever. But the idea is that each of these tumour-specific research consortia actually lead their own projects. You don't have to put your data in. The first step is you agree to work globally to define the data dictionary and then look at what you've got and try and put it in that format. So we're at the early stages. We, as a SIOP renal tumour study group, I'm trying to persuade our steering committee that we should go into this and work on the data dictionary as the first step. But then, of course, it means you can actually do cross-cutting analyses and more international benchmarking much more easily. And I know we heard at our national meeting yesterday from James Nicholson, who presented the work done by the MAGIC consortium, which is germ cell tumours. They have now interacted with this consortium and are seeing this as a way forward, because it's extremely well resourced. It's got moonshot initiative money, etc. And managing big data and making sure the information governance and access and outputs are all tickety-boo is expensive. You need a lot of people to do it properly. And then the other point I think you should always reflect on is we mustn't work in silos. So there are similarities between childhood and adult cancers, and how can we exploit them for the benefits of paediatric oncology? So variation in survival rates between countries isn't unique to our age group. And we do need to understand the reasons for treatment failure. We all need to be able to collect better information on stage, other prognostic factors like we've heard about the sequencing initiatives, the genomics, tumor biology, but also about treatment and outcomes. Most cancer registries now are able to collect or link to data, data on radiotherapy, electronic chemotherapy prescribing, all these things, all these machines can put data into places, and the question is it linked to your cancer registry or not? Cancer incidence going up. Well, in adults, it's mostly going up because people are living longer, but also they're fatter or they don't move as much, and they're drinking more. I mean, smoking's going down massively, and of course things like vaccination against hepatitis B and HPV will hopefully remove certain cancers, but other lifestyle factors are really increasing risk. And then, of course, many rare adult cancers face exactly the same challenges we do, that they need to work at huge scale, and that they've got problems of quality of coding and interpretation. So we need to work together. And so I'll just am I allowed a few minutes to say something about the global initiative? Okay. So WHO and IARC have got various global strategies on cancer. Ah, Martin, good to see you. There's the Global Initiative for Cancer Registry Development, and there's a specific arm of that on childhood cancer registries. And they're working, particularly in sub-Saharan Africa, to help them apply the Toronto staging to certain cancers in Zimbabwe, Uganda, Kenya, I think. And not surprisingly, they find that over half the children have got very advanced or metastatic disease at diagnosis, compared to probably less than a quarter in our sort of setting. There is a global strategy to accelerate the elimination of cervical cancer through HPV vaccination. And I heard a very nice example of a clinic in Africa where their childhood cancer survivors who are female, they are offering them HPV vaccine as they get, a certain amount of time off therapy. So let's work together. We need to get the vaccine out there, and we've got patients who are probably at increased risk. And then the Global Breast Cancer Initiative is really about building capacity to and having integrated national cancer control programs, and we need to get children in there rather than always trying to do something separate. So who knows about the Global Initiative for Childhood Cancer? Has anyone, who's heard of it? Gosh. No, go on, put your hands way up if you have. So it's okay. So, I mean, this just reminds you about, the need for advocacy. And if you're going to communicate something, you've got to say it at least 7 times. This is an initiative that really only got off the ground through years of advocacy. And then St. Jude Global finding $50 million to work with the WHO to make it happen. But it only got launched in September 2018. And the idea is that we're trying to get survival in all countries up to 60% by 2030, and in that way save 1 million lives. That's a sort of message. And there's this Cure All is the acronym for how to do it. So the key message is that childhood cancer generally cannot be prevented or screened, unlike most adult cancers, and that improving outcomes require early and accurate diagnosis followed by effective treatment. And that treatment can be effective with generic, inexpensive medicines, and it's very cost-effective. And there's quite a number of publications now showing that you can treat childhood cancer quite economically in countries like Ghana. We also know and understand the causes of treatment failure, and they're listed here on this diagram. And of course, they vary by national resources and social settings and so on, but they can all be improved by specific initiatives. And do read papers by Scott Howard about the work he's done in Central and South America to see how effective that can be. But the great thing about the Global Initiative for Childhood Cancer is it's got the Director General of the WHO, Dr. Tedros, right behind it and shouting, he wants to know what progress is being made. And that's very important. And the cure-all, which is these 4 sort of key things, I'll just go back one, stands for 4 things: centres of excellence, universal healthcare coverage, regimens for management and evaluation and monitoring, so that's kind of cancer registration. And then the enablers are advocacy, leverage financing, and linked governance. And then you can break this down into a number of project areas, and if countries want to put their hand up to the WHO through their Ministry of Health to say, we want to be a WHO-focused country for this global initiative, they then convene and organise a national workshop, and St. Jude and SIOP and CCI, the parents' organisation, and many others have been instrumental in helping them and providing people to go to those. Of course, COVID has somewhat slowed it down, but some of them have happened virtually. And then the local teams, the local leaders, decide which, 2 or 3 projects off this list areas they want to work in. And governments are also advised to take these 6 tumours as index cancers that they can measure, because if you can treat all of these successfully, you've probably got together your multidisciplinary care, your surgeons, your radiotherapy, et cetera, and all of these need earlier diagnosis as well. And just to give you an example of how it can actually work, so this is Liliana Vasquez, who's now SIOP Continental President for Latin America, but she's an amazing paediatric oncologist who's really driven this with her with ever-changing ministers of health in Peru. So they only started reviewing the publications about what's going on in our country back in 2016, and she's managed to get a childhood cancer law enacted, to get universal health coverage, et cetera, and even now they're going to join the renal tumour study umbrella. So that's all in 5 years. I think that's pretty amazing. I think I'm going to skip the next bits, but just to emphasise, sorry, these two were just some questions. Everybody has the same questions. Parents, healthcare providers, they want to know they're doing a good job. But, where are the data? And the thing I wanted to just focus on is that actually there's an awful lot of data about us out there in social media that we put out there with what I would call uninformed consent, because you can't use anything like your bank or social media unless you consent. And the fundamental message is that data does save lives. And I hope to see you in Barcelona. I'm allowed to get my advert in.